All right, welcome to The Explainer. Today we're diving into something that's, pretty rare but incredibly serious. It's a condition that connects a disease many of us have heard of, tuberculosis, to an outcome that is just devastating, paralysis. Yeah, you heard that right. We're going to follow the journey of this disease from the lungs all the way to the spine and figure out exactly how this happens.
So, let's just get right to it. The big, kind of shocking question at the heart of all this. How on earth can a lung disease cause paralysis? I mean, it sounds impossible, doesn't it? Well, the answer is all about how TB, this sneaky infection, can actually escape the lungs and set up shop somewhere totally different, our skeleton.
And to really get our heads around this, we've got to look at a little bit of anatomy. See, this disease doesn't just show up anywhere. No, it's very picky. It targets a very specific and unfortunately very vulnerable part of our spine. And there are some really good reasons why.
So let's be clear here. Pott's paraplegia isn't some brand new disease. It's really the terrible consequence, the neurological fallout, that happens when a TB infection decides to move into the bones of our spine, specifically the vertebrae in the upper and middle back, what doctors call the thoracic region. And once it's there, it starts putting the squeeze on the spinal cord.
You might be wondering, why there? Why the thoracic spine? Well, it's basically a perfect storm of bad luck. First off, the tunnel for the spinal cord, the spinal canal, is naturally at its tightest right there, so even a little bit of swelling can cause a huge problem. Then you've got the natural forward curve of your upper back. The infection can make that curve way worse, leading to a serious deformity. And to top it all off, the blood supply in that area is just not great, which makes it super hard for the body to fight off the TB infection. All of this together makes the thoracic spine a prime target.
Okay, so how does the paralysis actually happen? Well, it's not a one-size-fits-all situation. It turns out there are actually two totally different ways this can go down, depending on when it happens and what the TB infection is doing at the time.
And this is where things get really interesting. You've got two different timelines, two different mechanisms. On one hand, you have early onset. This happens within the first couple of years, while the TB is still an active, raging infection. Here, the pressure on the spinal cord is coming from all the gunk the infection creates. We're talking abscesses, inflammation, all that nasty stuff. But then, you have late onset, and this one is a whole different ballgame. It can happen years after the infection is healed. In this case, the problem isn't the active disease, it's the wreckage it left behind, like a sharp bony deformity or scar tissue that's now damaging the cord.
Let's boil it down even more. What's the number one culprit in each case? For early onset, the usual suspect is a tubercular abscess. Think of it like a pocket of pus and infection that's just physically pressing right on the spinal cord. Simple as that. For late onset, it's more of a mechanical problem. It's the spinal cord being stretched day in and day out over a sharp, healed-over bony angle in the spine. It's like pulling a rope over a sharp edge for years. Eventually, it's going to get damaged.
Okay, let's shift gears and think about the patient. What does this actually look like from their perspective? How does it feel? We're going to walk through the progression of this, and it's a pretty tough journey, step by step.
So interestingly, before the major weakness really kicks in, the body often throws up a very specific red flag. It's called clonus, and it's this involuntary rhythmic muscle twitching. You'll usually see it in the ankle or the knee. A doctor might notice it when they tap a reflex or gently push on the foot. It's one of the very first signs that the nerve pathways inside the spinal cord are getting squeezed.
And after that first warning sign, well, the progression is grimly predictable. It starts with just general muscle weakness, some stiffness, maybe poor coordination. But then it gets worse. You get to a stage called paraplegia and extension, where the legs go totally rigid and straight. As the damage continues, that can actually flip to paraplegia and flexion, where the legs are drawn up and bent completely out of the person's control. And the final, terrible stage, complete flaccid paralysis. All muscle tone is just gone. The signal from the brain is completely blocked.
Wow. I know, this all sounds incredibly bleak. So let's get to the question that's probably on all of your minds right now. Can people recover from this? Is there hope? And what is it that determines whether someone has a chance of walking again?
This chart here lays it all out for us. Good prognosis versus poor prognosis. And you can see a pattern, right? The outlook is much better if the paralysis comes on slowly, if the patient is younger, and if they've been paralyzed for less than a year. But here's the big one. Early onset has a way better chance of recovery than late onset.
Why? Because the early kind is caused by inflammation and swelling, stuff you can treat. The late kind is caused by permanent physical bone damage. And, of course, having a less severe spinal curve and only partial paralysis, those are huge pluses too.
So what happens when the prognosis doesn't look so good, or when the first-line treatments just aren't cutting it? Well, that's when surgery enters the picture. It becomes the essential next move to, quite literally, take the pressure off the spinal cord.
But, and this is important, doctors don't just jump straight to surgery. The first line of defense is what they call conservative treatment. It's basically a three-part attack. The absolute cornerstone is anti-TB drugs, a powerful cocktail of medication to kill the infection. Then, you support that by keeping the spine still, usually with a brace. And finally, you have physical therapy to keep the paralyzed muscles from wasting away.
So when do they decide to operate? Well, there are some really clear triggers. If a patient tries all that conservative therapy for, say, 3 to 6 weeks and sees zero improvement, that's a big red flag. Another one, if the paralysis actually gets worse while they're on treatment, or if it came on super fast and suddenly. Any of those things tells the surgeons, okay, it's time to intervene.
Now, the logic behind the surgery itself is actually really straightforward. Think about it. TB attacks the body of the vertebra, which is the big, chunky part at the front of the spine. So that means all the bad stuff, the abscess, the dead bone, the tissue, it's all pushing on the spinal cord from the front.
And because of that, for decades, the go-to surgery was called an anterior decompression. Anterior just means front. Surgeons would literally go in through the patient's front or side, moving organs out of the way to get to the spine. It gave them a direct shot at the problem area so they could clean out all the infection and get rid of whatever was pressing on the cord.
But this is where you can really see how far medicine has come. I mean, going in from the front makes sense, but it's a huge, invasive operation. Today, things have changed. The new standard is called the transpedicular approach. Now, surgeons can go in from the back, which is way less disruptive, and they can actually reach the front of the spinal cord by going through a little bony tunnel in the vertebra. It lets them do the whole shebang in one go. Decompress the cord, clean things out, and even put in rods and screws to stabilize the spine. It's a real game changer.